It's Dr. Sabrina Siegel here to introduce a brand new special series brought to you by the NEI Podcast. Welcome to the PsychopharmaStahlogy Show. In this special series, Dr. Andrew Cutler interviews Dr. Stahl on the most controversial, novel, and exciting topics in psychopharmacology today. Every 3 months, we will address a different theme in psychopharmacology. Each theme is split into 3 parts, with 1 part released each month. The first theme is on psychedelic-assisted psychotherapy as a novel approach to the treatment of psychiatric disorders. Let's listen in to Part 3, Forgetting Your PTSD, using Reconsolidation to forget traumatic memories.
Hello and welcome back. This is part 3 of a 3-part series in the PsychopharmaStahlogy podcast series sponsored by the Neuroscience Education Institute. I'm Dr. Andy Cutler, Chief Medical Officer of the Neuroscience Education Institute, and this is part 3 called Forgetting Your PTSD, Using Disruption of Reconsolidation to Forget Traumatic Memories. With me, of course, is the inimitable Dr. Stahl. Steve, how are you?
It's great.
Well, Steve, I'm really looking forward to this. In part 1, we talked about the concept of psychedelic-assisted psychotherapy. Part 2, we talked about addiction and how we can use psychedelics potentially to undo the addiction process. And now we're going to be talking about PTSD, where I understand there's actually a lot of research being done on this concept for PTSD.
Well, Andy, you know what we're going to do this hour? We're going to relax.
Sounds good.
In fact, maybe you and I won't do drugs to relax, but, there's a thing called relaxing your beliefs under psychedelics. And that's how you treat PTSD today. Some people call it REBUS, R-E-B-U-S, relaxing, R-E, beliefs, B, under psychedelics, although they say an S instead of a P. But there is this idea out there. That's how to get better. So are you relaxed? Are you ready to go?
I'm feeling ready to go here. But maybe you can help us understand PTSD is a form of fear conditioning. Is that correct?
Absolutely. Well, the amygdala is the center of all conditioning in the brain, and there are 2 major types. One's called reward conditioning, where you get addicted, and the other is called fear conditioning, where you basically have so much fear embedded that it can be triggered by sensory experiences that remind you of the time you got freaked out. And it turns out that in the second part of this series, we talk about how you could possibly forget your addiction. And the first part, we actually talked about, the power of psychedelic-assisted psychotherapy. But with all seriousness, what people are trying to do is to figure out how you could get into that amygdala, and it may not be accessible to psychotherapy for all people, or for a lot of them, in a normal state. Now, we do know that one way to neutralize your fear conditioning is just with what's called systematic desensitization. It's an old-fashioned thing. You're fear of snakes. You think of a snake until it doesn't bother you. Then you look at a picture of a snake until it doesn't bother you. Then you look at a snake in a glass cage until it doesn't bother you. Then you touch it and so forth and so on. And you as much anxiety as you possibly can stand, sustained over time, desensitizes you to it. And that's exposure therapy, is the one therapy that actually the National Academy of Sciences says works the best for PTSD. And that is that those people who can do it try to re-expose themselves to things that were associated with the original trauma, like soldiers or domestic, would be policemen or rape or whatever it is. Now, the problem with that is that it takes a long time. Secondly, over half of people who are candidates for it cannot tolerate the exposure. And finally, about the people who actually have a response to it, about half of them relapse. So although it's the best, it's not very good. There's another way to neutralize fear conditioning, and that is to inhibit it. And this gets into theories of memory. We touched a little bit about that, and we talked about how you forget to be addicted. Well, if you remember to be freaked out by conditioning your fear, how do you forget that? And it's no longer a memory. How do you forget your addiction? Same kind of process, because it turns out that getting PTSD is a form of learning. I would say a diabolical form of learning. Evil! But it's the part of the brain actually, has some of these memories in it. A saber-toothed tiger is not a good thing to have chasing you. So as a caveman, we learned a long time ago to get freaked out by that and run fast so you didn't get eaten. But now that same darn reflex is in there so that when you're a soldier and you see the buddy next to you have a horrific wound and maybe get some of the brains splashed on you, you are traumatized and have your amygdala so conditioned that anytime you hear gunfire, anytime you think of your buddy, anytime you feel warmth on your face, you freak out with the symptoms of PTSD and panic, etc. So how do you unlearn something that atrocious? And that's what we're talking about. Using drugs that change memory, like psychedelic, dissociative, or empathogenic drugs. Wow. And to loosen yourself up so that the psychotherapy will work.
Steve, you talked about learning. Is this actually the process of forgetting the memory, or is this a new learning on top of the memory?
Well, that's a really, really good point. It's not clear that we actually forget very much. What we do is we learn something that replaces what we've previously learned or blocks it. Particularly you, Andy. I don't think you've forgotten anything since childhood. No, all kidding aside, it's really true that those are deeply embedded in our brain. That's why hypnosis can bring them forth. That's why good psychotherapy of people who have had traumatic early childhood experiences that have forgotten them can have them come to the surface because they're in there. So how come you could maybe stop that? Well, you can't really go in there and take a neurosurgical probe and electrolytically knock out the neuron that has it in it. What you have to do is form a new synapse and stop it. And that's really what we think happens in the amygdala. There's fear conditioning, which is caused by the formation of a memory. So if you provoke the idea of what the smell of the guy was who was raping you, or the fear of the feeling of the blood on your cheek, those are sensory experiences. They're memories, but then they trigger an association with how horrible you felt and the sort of subjective symptoms of PTSD. So that association can be blocked. And that is what happens when you remember it. So years later, when you remember those sensory experiences, it activates the memory in the brain, creates an unstable situation which allows you to modify it. Now, most times when you have PTSD, you have it and you reconsolidate it. That's what it's called. You have the original memory, consolidation. You have it, you're experiencing, you're remembering it in the consciousness, and then you bury it back down again and reconsolidate it and keep it just intact. Well, what we are trying to do is that during that phase when you're remembering it, to modify it so that it isn't reconsolidated. And animal studies shows how to do that. You can prevent reconsolidation with various neurochemical techniques and actually with various learning paradigms. And what happens is that to answer your question in a long-winded way, you are forming a new memory to block the old one. So that's called inhibiting reconsolidation. So that's what we want to do. We don't want people to have their memory. So guess what you do? You have certain embedded beliefs, and the point would be, can you have the memory in a neurochemical environment that makes it vulnerable to being disrupted? And that's what this idea of relaxing your beliefs, psychedelics. And so, you can relax we're just getting the beginning of this. We don't know how to do it, but we certainly know that psychedelics that are hallucinogens stimulate 5-HT1A, or 2A and 5-HT2C receptors. We know that dissociative agents like ketamine are NMDA glutamate blockers. Mm-hmm. We know that empathogens such as MDMA are amphetamine-like objects that are changed into serotonergic instead of dopaminergic agents. And it turns out of the three, the best future is with the MDMA ecstasy agents. For whatever reason, I don't know whether it's mechanistic or they just studied it more. The best promise is to try to relax your belief while you're having an ecstasy trip. How about that? So what is ecstasy? I told you it is, if you will, an amphetamine derivative. And although seeing a hallucination of what's not there, funny colors with LSD, or dissociation, which means you just don't even know who you are or where you are with ketamine, empathogens create an altered state of consciousness with experience of, people say they feel emotionally communicating with people in a way that they can't normally, without even using words. They feel a oneness with other people or with the universe. They feel relatedness to the universe in general, people in groups, but also whoever you're with a form of both empathy and or sympathy. So it seems to provoke those feelings, and it's when you're in such a state that it appears that you will disrupt the conditioning of fear that's associated with the memory you're having while empathic. Isn't that cool?
Steve, this is fascinating because if you think of some of the symptoms of PTSD, they include numbness and desensitization, things like that. So this is almost the opposite. It's reversing that.
Right. And that is what we need to do. It turns out that you have MDMA, but unlike some of the ketamine work and some of the psilocybin work, which we talked about in the first and the second parts of this series, and those would be related to more addiction or to depression. In those cases, you're giving a type of psychotherapy which is called motivational enhancement therapy or cognitive behavioral therapy, where you're basically helping draw out of the patient at your direction as a therapist their feelings and getting them to articulate that and coaching them and rooting them on. In the case of MDMA and PTSD, you're not doing that. The best data anecdotally seem to be able to have a setting that is safe. Because unlike having memories of, let's say, how terrible you feel as a depressed person and how worthless you feel, as bad as those things are, and they are bad, they're not as bad as re-experiencing the trauma that you had when you had your first PTSD experience. So that's a very dangerous thing to have happen. And it's better to have the patient in control of that, to start remembering it at their own pace. So before the sessions start, you try to coach them about, we're going to try to approach this, maybe only very peripherally. How old were you at the time? What else were you doing? Not at the time of the exact trauma, but were you in the Army at the time? What was your rank? Very close to the idea, what were you doing? What was your duty? Were you married at the time? What was happening in your family at the time? And allow them, to say, we want you to direct this, and I'm not going to ask you these questions, but I'm telling you now what I want you to think of yourself, and to get as close to the experience as you can in a safe way, and so that you can actually relax your belief. The belief that you have, or the memory you have, is that anything that feels like blood on your cheek should trigger the most catastrophic PTSD reaction ever possible in your brain. That's a dumb memory, but it's in there. So if you can relax your beliefs, begin to have some insights to it, handle it so that it's not too hot to handle, it's not as unapproachable, the patient does it at their own pace. So you create an MDMA altered state of consciousness, MDMA, of course, is ecstasy. It's a form of amphetamine that works on serotonin more than dopamine. And in that state, you sit with the patient, and you may guide them very indirectly, but it's really as much as the patient can take sort of thing. And they usually will self-pace and approach this because they'll find that they can, remember I talked at the beginning? It desensitizes it.
Exactly.
But it's not you making them go too fast. They can go as fast as they want. Make sense?
Yeah, it sounds like a form of pharmacologic desensitization or exposure, but you're exposing them not to an object, but to a memory.
Well, if it's too hot to touch, you can never get at the memory. Right. And so the idea is that the empathogen relaxes you. So you can approach the otherwise horribly unapproachable. Can you imagine having these atrocities in combat or domestic first responders atrocities of people burning or rape? These are the common things, or assault, automobile accidents. These, when they happen, you can't think about them again. And it actually makes it worse because it basically allows that thing to be triggered so easily. And so what it's doing, is allowing you to relax your belief and to make it possible to approach the unapproachable.
Steve, something that's always fascinated me about PTSD is a lot of people are exposed to trauma, but not everybody develops PTSD. So there must be a genetic diathesis here.
Right. Well, when you have a traumatic experience, about 100% of people feel bad at the time. About half of people will actually get a form of an acute trauma-like experience, but half of those will go away in 30 days, and who knows whether that's really a biological thing. If you look at the DSM, you can have an acute traumatic reaction that is about half the people are biologically able to get rid of it. And although it's horrible, and they certainly don't like it, and they're nice people and everything, but they're not traumatized for the rest of their life. So what is it about that maybe 25% of people that are first responders? So you have 4 guys, gals, whatever, go into a burning building.
Right.
Everybody's freaked out till the next morning. 2 of the 4 are essentially have a form of short-term PTSD, and one of them neutralizes it in 30 days, and the other one has it for the rest of their life. What's it about that?
Exactly.
So one wonders whether there's some sort of an innate ability to desensitize yourself. You see this in OCD. Some people can learn that being afraid of a light switch is one of the best ways to do that is to not allow yourself to go and check it. And if you realize that, after a while, you feel very anxious at the first time you're not allowed to check it, but then soon it doesn't bother you not to check it. Some people can do that to themselves. Those who have really bad fear conditioning can't. So the idea is that this allows, through facilitating the extinction process, to accelerate it so it happens under a couple of different sessions. And this is the other thing, is that the plasticity of the brain is absolutely remarkable. At least yours, Andy. On my mind, I'm getting up there and you don't know about it.
I don't know. Yours is still pretty good.
Well, even in old folks, adults, can actually form new synapses.
That's right.
What we're learning is that you can provoke this with certain drugs, and it can happen real fast. The monoamines that we use, let's say for PTSD, first of all, do they really work? Like SSRIs, I guess some are approved, but anybody who's listening to this who's actually treated PTSD with SSRIs, I'm sure, are completely underwhelmed.
Yes.
It helps the depression comorbidity, but to what extent it really helps core symptoms is certainly not a cure. And when it does occur, it occurs with a delay. And it turns out that the change of plasticity that we're used to from using so many SSRIs and antidepressants in our practices, we get used to the brain can't change for 6 weeks because that's how long it takes, 12 weeks. But how about ketamine that works in 20 minutes? How about empathogens that work in 20 minutes? How about neuroactive steroids that act in 20 minutes? What it's saying is you get the mechanism right, your brain can sprout new synapses, bang, just like that. And that's about what we need for treatment-resistant conditions, and people do not want to be treated for 6 months if they could be treated in 6 hours or over 6 weeks. So we need to be beginning to think outside the box. Can we treat the untreatable, and can we do it fast?
So you're saying the final common pathway here is synaptogenesis.
There's a lot of evidence that that is the case, and that what has to happen is synapse formation. And as you mentioned before, it's not so much losing a synapse where you have a bad memory. It's gaining a synapse that blocks that bad memory in just the right place.
Psychopharmacology podcast listeners know how effectively Dr. Stahl's books improve their understanding of a complex field. Good thing there are so many publishing this year. Like the 7th edition of the Prescriber's Guide, it's out now in paperback and spiral-bound formats and features 9 new compounds, injectable and transdermal formulations, and updated warnings and indications. Or the long-awaited 5th edition of his textbook, Stahl's Essential Psychopharmacology. It includes over 500 new or refreshed figures, an intuitive color scheme, 14 new uses for older drugs, 18 brand new drugs, and much more. Not to mention a new handbook, Suicide Prevention, with Christine U. Moutier and Anthony Pisani, Practical Psychopharmacology with Joseph Goldberg, and many more titles. Visit cambridge.org/NEI to learn more and get 20% off your order. I see. And so these effective medications we can think of as creating more synapses, more dendritic sprouting, more dense connection, more arborization of the brain. It's remarkable.
Well, it might do that, Andy, in a way that is like non-specific. Yes. So that when you've seen these kind of rodent studies that they've done with ketamine, and it shows these dendrites just popping up all sorts of synapses, that's maybe happened all over the brain. But what we think happens is that if you're doing it in a state of consciousness where you're directing your memories and your attention to a certain type of thing, that instead of sprouting just willy-nilly all over the brain, you're actually doing it at the place where you're needing it. It's sort of like, when you have a glutamate being used, the channels open. When you have GABA being used, the channels are open. So those are the fast ones. Neuroactive steroids act on GABA circuits. Ketamine acts on glutamate circuits. And what happens is that it's use it or lose it. And what you can do is to say, okay, randomly, my brain's got some synapses open. I'm sitting there maybe not thinking of anything. But whatever is happening in my brain, those are the synapses that are working. Well, what if you on purpose activated the synapses that are the problem with your psychiatric disorder? And you do that by directing your attention to them. Then when you give the drug, the synaptogenesis is directed to those selectively. That's the idea.
That's fascinating. So you can almost target the effects here. That's remarkable.
Right. Okay, let me talk about something like pregabalin or gabapentin. These are drugs that are directed towards glutamate circuits that have a certain receptor to it, a channel, an ion channel.
Right.
But that drug will only work when the channel is open. So how can a drug work for pain, anxiety, sleep, and epilepsy? The same drug. What is it, psychiatric penicillin or something? No. It's basically only working where the channels are open, because the drug is going to be directed towards use-dependent channels. So if you're seizing, guess what? Those channels are open. Your drug's going to go there. If you're anxious, those channels are open. And if you have pain, different ones. So this is the general idea, is that what you're trying to do is activate the needy circuit, the pathological circuit, the one that's not working. Remember, all psychiatric disorders are symptoms. All symptoms are basically run by networks that are having inefficient information processing. So what you want to do is get out and ride that inefficient information processing so it's active at the time you give your MDMA. And you can do that by having a psychotherapist help you think about those things that are going to activate that circuit. So when the drug is there, you can be acting on these plasticities selectively there. And with the right type of thinking, try to block it.
So how can serotonin work in this way? MDMA, you're saying, increases serotonin. Why wouldn't SSRIs work?
That's a good question. And I think the answer is that SSRIs probably only increase serotonin in a very narrow band, because you're only going to increase the serotonin that's released.
That's right.
You have to have normal release. And in many of the states, we think serotonin may be deficient. So what's happening is that whatever's being released physiologically, that gets reuptake blocked. So if you don't release any serotonin, SSRI wouldn't work at all. You take MDMA, it's taking stores of serotonin and possibly flooding the synapse.
I see.
So you're having, and remember that you have 14 receptors for serotonin, and they all have different affinities. So the ones that are the weakest are going to get only activated in the presence of lots of serotonin. So it's possible that SSRIs don't have much of a range of increase of serotonin compared to what would happen with MDMA.
Makes sense. Are there specific receptors that seem more likely to be the culprits here than others?
I don't know that we understand the MDMA story as well as we do some of the others. I think I mentioned that we are very clear that with the psychedelics, like hallucinogens, whether it's LSD or psilocybin or mescaline, those drugs pretty much selectively act as agonists to stimulate mostly 5-HT2A and to a lesser extent 5-HT2C receptors. So they're agonists at 5-HT2AC receptors. MDMA, it's not known, it is actually a form of amphetamine that gets into the neuron on the reuptake pump, and then it gets into the synaptic vesicle on the vesicular transporter. And when it does that, it shoots all the stored serotonin out, first into the cytoplasm of the presynaptic neuron and then into the synapse. And whether it's playing on one selective receptor or another is not well known. But as I mentioned, I think in another one of these podcasts, if you want to stop MDMA from acting, all you have to do is give an SSRI, because it won't work unless it releases serotonin, and it can't do that unless it gets into the nerve, and it only gets in the nerve by hitchhiking on the reuptake pump. If you block it, it won't get in. So it basically is one way to actually stop it from acting. But once it's in, I guess the question is, what happens? We do know that if you flood it too much, you will get hyperthermia. And if you remember your old studies, what happens when you give an MAO inhibitor with a serotonin reuptake inhibitor, other than the fact that you die? But the answer is that you get hyperthermia, which is basically part of that serotonin syndrome. And it's from the incredible release of serotonin that occurs in that situation. What happened with MDMA ecstasy people going to rave dances all night? They dance, get dehydrated, overheat, and they had heat strokes of young people because the MDMA combined with exercise that was generating heat created hyperthermia. And so some of the action of MDMA, at least at toxic levels, was hyperthermia. Now in the office, you're not going to give anywhere close to that kind of a dose. What you're trying to do is create a safe level of empathy, or just provoke this idea of emotional connection and oneness, so you're calm and you can accommodate thinking about the most horrific thing that happened in your life that gave you your PTSD.
What is the evidence here, Steve? Is there evidence that these drugs actually work for PTSD?
It's beginning to. So if you take all these psychedelic assisted psychotherapy together, the best evidence for PTSD does come from MDMA, and MDMA does not have a lot of good evidence outside of PTSD. It has some beginning evidence in depression. Ketamine, of course, is best in depression, but has started to work in substance abuse. You end up having psilocybin. Actually, the best evidence for that is in the treatment of anxiety associated with dying from cancer. And more recently, also treatment-resistant depression. So we're trying to figure out what the pharmacology is and what kind of therapy to add and where the therapeutic targets should be. But the answer to your question is that if you're trying to figure out what's the best lead on getting your PTSD better, right now it's MDMA, basically assisted psychotherapy.
Yeah. Anecdotally, I've heard of patients getting ketamine for PTSD and it working dramatically well right away. But
See, I've heard that as well. I don't know that it's been much public. Are there any studies that
I don't know of any good, carefully designed studies. And a lot of it's anecdotal. It's case series, case reports. I don't know that a large placebo-controlled study has been done. As a matter of fact, a nurse who works with me, her husband has bad PTSD, and he finally went to a ketamine clinic. And after the first infusion, it was dramatic, according to his wife.
I don't think we should discount the possibility that there's widespread uses of anything that is causing new synapses forming. And who that is best suited for and what setting it would be best in is right now so exciting as a possibility. I don't know how many people listening to this treat PTSD, but it is so heartbreaking. I've consulted with, of course, the VA, but also the Army when these younger soldiers are starting to get PTSD, and it's just heartbreaking. And the other thing that's interesting, when does PTSD get treated? Oh, let's say, how about the Vietnam veterans, 50 years of their PTSD? What do you think the chances are that a Vietnam vet who's so reconsolidated their PTSD for 50 years is going to be a good candidate compared to what I actually have proposed, and some people think it's outrageous? How about doing an MDMA experiment or a ketamine infusion on a soldier 20 minutes after the blast injury?
Yeah, that would be amazing.
On the battlefield, one of the things that's interesting about this consolidation idea is that you have heard that if you give someone a beta blocker after a traumatic experience, it may reduce, but some studies have failed to replicate this, it may prevent you going on to get PTSD. Another study that wasn't controlled, but still quite interesting, is that they did a study of the people who were injured on the battlefield in Iraq-Afghanistan war, and they looked at who got morphine injection for pain within an hour of the injury and who didn't. And they looked at the incidence of PTSD, and the morphine mitigated at least 2/3, I think it was, of the PTSD. So part of this has to do with the brain is plastic, but it may very well be that if you overlearn something because you've had these experiences and reconsolidated it and reconsolidated it and reconsolidated it without modification, without blockade, what are your chances 50 years old or even 5 years older? If you look at the Iraq-Afghanistan veterans, they often are sitting around getting discharged from the Army for up to 2 years after they've had their condition, and they go to the VA and they have years at a minimum since the event. It's good to jump on those right away. Of course, the earlier the better. It doesn't mean that your brain can't change no matter how long it's happened. But what isn't really being taken account of is the possibility that this kind of intervention might be more powerful the closer to the traumatic event than it is.
It also occurs to me, we're talking again about drugs that have addictive potential. What do you think is the potential for abuse using these kind of agents to treat mental health conditions like PTSD?
LSD is abusable, and MDMA, people go to parties and that's abusable, and even ketamine and particularly PCP are abusable. It's not heroin. And I think that the way that they're abusable tends to be because they want to have a dissociated experience to escape their pain. And they want a holiday. They want a vacation from their psychiatric symptoms. And being stoned or even just plain marijuana or whatever is better than having their pain all the time, or their psychic pain, whatever it is. And I think that the drive to do that is going to be mitigated greatly if we can relieve their suffering in a way that's more adaptive. These same drugs, you're going to treat PTSD by getting them addicting drugs. That's good stuff. Where'd you learn that one? What you've been shoving up your nose? So, the idea is, I want to give addicting drugs, but they're not addicting the way we're using them. The way you use these drugs is at low doses.
Right.
That slowly increase up to their peak, that stay there for a longer period of time, hours, and then come right back down again. The way you abuse drugs is to smash your receptors, do it suddenly, completely, and then rapid release so that the drug is getting out of your system quickly. That causes basically an addictive type of response. So you can use the very same drugs in a different way and get entirely different results. And so the proof's in the pudding. If this stuff doesn't work, then I think that we shouldn't use it. But my God, we're beginning to think outside the box. Who would have thunk it that drugs that have been characterized as being Schedule 1, only problems, no efficacy, only safety problems, would be useful for the most treatment-resistant problems in psychiatry today? Wow.
The brain's agnostic, of course. The brain doesn't know that these are abusable drugs. The brain just knows, hey, this drug does this to my receptor or this to my chemical.
No, Dandy, it's not right. The brain reads the DSM and conforms to it. And the DSM was actually, the brain came out of the DSM.
Mm-hmm.
Wait a minute. I think the people who wrote the DSM have brains and the DSM came out of the brain, but sorry. You're right. Agnostic, absolutely.
Right. The brain doesn't know the difference between legal and illegal. The brain just knows these are chemicals.
Right. And I think that unlike maybe cancer therapy, where there's much more science involved, and in medicine that has to do with the brain, and particularly in psychiatry, there's a lot of serendipity involved.
Right.
And our whole history of the major classes of psychotropic drugs that have been found have been initiated and triggered by serendipity. I think this is what's happening here. You need to look at what is valuable in here and not prejudge it. You need to check the data and then do the right trials and figure out what's happening. But I actually think that psychedelic-assisted psychotherapy, if that's what you want to call it, and there's also, they call this rebus, relaxation of your beliefs, which is the same thing, but under a different name. Using that with the right type of training in psychotherapy, we're not talking about doing 2 years of this, we're talking about doing 2 sessions of it, could actually be transformative in our field. How well do we treat addiction? How well do we treat PTSD? How well do we treat these horrible patients that don't respond to anything for depression? We need to think outside the box, because what insanity is, that old joke, is doing the same thing over and over again, expecting a different result. This is something different.
Exactly, and it requires certainly new regulatory frameworks. It's going to require training. It's going to require us rethinking the way we deliver care. It's going to require changes in the reimbursement system, because how do you get these kinds of things reimbursed?
Yeah, and it's going to require possibly psychotherapy training, and it's going to require us to be alert to basically charlatans that are going to use this to make a lot of money by gimmickry and so forth if it's not regulated and the science isn't well known. So we have to protect ourselves against raising false hopes with patients and having people do some of this work just to make a lot of money by running it through a mill or a clinic or something. This is serious business, and having said that, people can exploit it. The reality is that's worth trying to risk that in order to get serendipity and keeping your mind open and shift paradigms.
So you actually think there might be a future for this?
I really do. I think that in areas particularly like treatment-resistant depression, PTSD, which, there's no such thing as a PTSD that isn't treatment-resistant, and we have no treatment really for addiction. You can hope that some people stop, but there's no treatment that really works with any sort of good outcomes. So I think that we're desperate. We can't afford to prejudge things without looking at the data. And the data that you see is beginning to shape up. We need a lot more of it. We need government support of it, because it's probably not going to be all that commercially supported. Although I can't say, there are a number of ketamine-like drugs that are in process that could do, and there are a number of neuroactive steroid-like drugs.
That's right.
Whether we're going to actually, and in fact, that may actually be the same thing. Andy, why do these drugs work? Because they're neuroplastic. It just so happens they're also mind-altering. Is it possible that you could have neuroplastic without mind-altering? And that would be maybe neuroactive steroids or certain ketamine or like NMDA acting agents. We might have our cake and eat it too, which is to not have to experience and pay the price of mind altering. We want synaptogenesis. Mind altering is a side effect.
Interesting, fascinating. Of course, also some of these drugs we're talking about are available on the street, and people can get them and use them. The problem there, of course, is, as you said, the dosing, the way it's released into the brain, and this kind of thing. And it's also, what we haven't talked about, too, is not only what drug you're using, but also the setting that it's given in, and the particular type of psychotherapy, which obviously has to be worked out. But if it's given in a setting that's conducive to conditioning for craving for the drug, that's obviously not therapeutic.
And the same thing, some people have exposure therapy, and the last thing they want to do is be around a group of other veterans who they're afraid of or don't like or whatever, and they do group exposure therapy. They can't stand it. You need, in many cases, a quiet, dark room with somebody, and you can't necessarily say, hello, my name's Dr. Cutler, I just met you 5 minutes ago, let's go talk about your most intimate details under this drug. It may be that you have to have rapport with that person, establish a track record, get some trust involved, so a trusting, calm atmosphere, and those are going to be tailored to the individual patient, because what's calm for one person isn't necessarily calm for everybody.
Yeah. There was an article many years ago, I remember, that talked about various forms of psychotherapy and which ones were more effective. And what it found was it didn't matter so much the form of psychotherapy, it was the quality and nature of the relationship between the therapist and the patient.
I think that's absolutely true. There's something magic about human connectedness, and maybe in some of these ways, these drugs help let down your social barriers so that you can get to that, but it really is that connectedness. Mm-hmm. And again, I'm reminded of some of my old psychotherapy training. And yes, don't snicker, I've had psychotherapy training. It's listening, not hearing, listening, active listening. If someone listens to you and you know they're listening and they're suspending their judgment while they're doing it, it has this curative effect. That's something about human nature. And so exploiting that when we need it for things that are otherwise untreatable and getting the relationship right and training people so that they can get that relationship right is everything we're looking at.
The problem is, of course, psychotherapy takes time, weeks, if not months, if not years, whereas this combination, as you like to say, the 1 + 1 = 10, this combination of psychedelic-assisted therapy, maybe this is a way to accelerate that process and get even better results.
Yeah. People are impatient and they want rapid onset. And what's interesting in all of these new cases is that the synaptogenesis and the changes in your consolidation and the synapses associated with that are immediate. They're right away. You're right. We don't have to have 2 years of psychotherapy. Most of the studies are done with 2 sessions of a couple hours each. So it's amazing.
It is amazing. And yet the effects can be lasting, which is incredible. You think about our typical monoaminergic manipulations with reuptake inhibitors, you're flooding the brain with serotonin right away, but something has to happen downstream, clearly, and maybe we're cutting to the chase here, cutting right to the effect that really matters.
And if you think about the types of, like, social anxiety disorder, if you learn how to desensitize yourself to that, that is actually more powerful and enduring once you stop having therapy for that than it is to take an SSRI for that. People need to keep conditioning themselves to keep them in a social environment so that they don't go backwards. But it's that process that is enduring, and you don't need a drug around anymore. Once you've learned it and the synapse is there. So how do you hasten the psychotherapy of behavioral conditioning or exposure therapy, or even just a cognitive behavioral therapy? Those are forms of learning, but they could take 12 weeks, 24 weeks. How about 2 sessions of 4 hours?
Wow, that would be remarkable. And speaking of remarkable, this has been a remarkable session here. We're out of time. Thank you very much, Steve. This has been really mind-altering in a number of different ways, literally and figuratively. And so I want to thank you, the audience, as well, for listening to this part 3 in our 3-part series of the PsychopharmaStahlogy podcast series from NEI. And this one was entitled Forgetting Your PTSD, Using Disruption of Reconsolidation to Forget Traumatic Memories. Don't forget to listen to parts 1 and 2. Part 1 was general talking about psychedelic-assisted psychotherapy, and part 2 was talking about forgetting to be addicted, using psychedelics to treat addiction. Thanks so much for your time, and thank you, Steve. It's been really fascinating.
Very good. Thanks, Andy.
This episode was brought to you by NEI Membership. The 2021 NEI Synapse Virtual Half-Day Series is included with NEI Membership. Become a member today so that you can register for free for any or all of the monthly half-days, in which Dr. Stahl and colleagues will spend the last Saturday morning of each month sharing cutting-edge research and clinical insights on the topics most relevant to real-world practice. Don't miss out. Become a member today. Visit www.neiglobal.com to learn more.